Good evening, everyone. Thank you for joining the NATF online support group. We are here tonight with Dr. Umberto Campia, who is a cardiologist and a vascular medicine specialist at Brigham and Women's Hospital and a member of the faculty at Harvard Medical School here in Boston. So thank you, Dr. Campia, so much for joining us this evening.
That's my pleasure. Thank you for the invitation.
Of course. So our format this evening is a little different than normal. Typically, we have a presentation and then have some questions specific to the presentation. But we thought that we would go ahead and open it up to you guys and just answer any questions that you had on your mind. So a lot of you, we had got several questions on social media and through the info box, which is great. So we've compiled a list of those. If you have questions that come up during the presentation, go ahead and just answer or ask them using the questions function on the GoToWebinar control panel. It's the second little dark gray box down. If you just hit the little arrow next to it, you can type in your question and send it straight to me. It doesn't need to go to the group, and I will make sure that Dr. Campia addresses it.
Absolutely.
Just to give everyone a sense for how I organize the questions that we have tonight, we got so many, I organized them into 3 categories: diagnosis and symptoms, treatment and medication, and recovery. So each question kind of was able to fall into one of those buckets. So Umberto, if you are ready, then we will go ahead and start with the diagnosis and symptoms.
Absolutely, I'm ready as I can be.
Okay, perfect. So, sorry, we're in a hotel, so it just got a little loud. So this individual had a nail removed in April 2019. And then they had a pulmonary embolism in May. Their hematologist testing revealed nothing, but then they also had 7 days of bed rest with pneumonia in May. However, they're being told that this is not a provoked pulmonary embolism, and they're wondering why that is.
So, definitely the toenail surgery, as much as it would be considered a procedure, is not a serious procedure, is not one of the surgeries that are considered likely to cause a pulmonary embolism or even a deep vein thrombosis. The European guidelines, the most recent European guidelines that were published last year, recognize as major risk factors for the clots the surgery that has anesthesia of 30 minutes or longer. So for a toenail, you don't get general anesthesia. You get probably a little bit of numbing medication. So definitely the surgery would not account for it. With regards to the pneumonia, usually and again, the European guidelines come to our help with clarification, would be a serious illness. And the serious illness would be one that is associated with bed rest, strict bed rest for 3 days or longer, in which the only sort of mobility allowed is going to the bathroom. So if the patient had this type of event, so a serious illness with strict bed rest and going only to the bathroom, then this could be considered a provoking factor. Otherwise, the situation would not be likely to be a trigger. Now, the European guidelines also recommend to move on with regards to the classification of provoked or unprovoked, and recommend to use the term of a DVT or a PE that has no identifiable factors. And if a patient has no identifiable factors, the data that we have so far suggests that there is a risk of recurrent events of about 3 to 8% per year. So there is a wide range. And this is because you may have a person that has no other sort of minor risk factors such as an inflammatory disease or a previous history of superficial thrombophlebitis or some other predisposing factors such as varicose veins. In that case, the risk can be modulated or can be considered higher if you have these risk factors or lower if you don't. So at this point, it's going to be more a I would say a weight risk rather than a provoked versus unprovoked.
Okay, so to kind of follow up on that, we got another question from a patient who had an unprovoked DVT, and they were prescribed Eliquis for life, but he has heard of other people where they were only on a blood thinner for 6 months. So he's wondering why there is such a discrepancy in terms of the treatment of unprovoked DVT.
So again, referring back to the European guidelines, the presence of a correctable factor, such as having been in a surgery or having had a major trauma or a major illness, tells us that if we remove the factor, the event is unlikely to recur. I always see this as a predisposition and sort of trigger. We have people that have a very light predisposition to develop a clot, and they need a very, very strong trigger to combine with the predisposition to cause the clot. And if you have a very low predisposition and you have a very high risk trigger, then if you remove the trigger, it's unlikely that you will get a DVT unless you have another very bad trigger. Instead, if you have a DVT or a PE without a trigger, it means that you have a predisposition. We cannot identify what this predisposition is in many patients, but we know that as a group, patients that have a predisposition like this are at risk of developing clots. At this point, we have to make the decision. Is the risk of not doing anything worse than the risk of taking the blood thinner? And the risk of taking a blood thinner is mostly bleeding. The risk of bleeding with the current treatments, particularly the DOACs or like Eliquis, like Xarelto, is relatively low. And the risk of having the clot is relatively high, and the benefit is in favor of taking the blood thinner. Instead, if you have a very low risk of having a clot and the risk of bleeding on the blood thinner is worse, you're not, getting any benefits, net benefits from it. And so at this point, the decision is not to take anticoagulation. The guidelines in the past that said provoked versus unprovoked try to sort of categorize this in simple ways so that practitioners could be guided in the majority of cases. So a patient comes in with an unprovoked DVT, well, it's very likely that in the future may have another clot and they may benefit from blood thinner. Patients with a provoked DVT may not benefit that much. So now we have a sort of rule of thumb, provoked and unprovoked, but we can refine it with our newer guidelines.
So to kind of summarize, I mean, there's a lot of different factors that go into deciding if something's provoked and unprovoked and what appropriate treatment for that should be. So probably the best thing you could do would be to find a healthcare provider who you can really have, good conversations with to decide what the best course of treatment is for you.
Yes, absolutely, Catherine.
Great. So this patient wants to know, is having postthrombotic syndrome a reason to stay on blood thinners? They had a DVT at 21, which is provoked by knee surgery. Then they had another DVT at 34, which is provoked by immobilization. And they developed post-thrombotic syndrome following the second DVT. They've been tested for the thrombophilias, all of which were negative. And her doctor wants her to come off the blood clots because they were provoked. And another wants her to stay on the blood thinners because of the post-thrombotic syndrome. So I guess kind of some general guidance about post-thrombotic syndrome and blood thinners.
So I have to say that if I had to take care of this patient, I would recommend to stay on the blood thinner. The reason, though, is not for the post-thrombotic syndrome. The reason is, and this is sort of captured in the American guidelines, if a patient has had 2 separate provoked events, even if they were provoked, they sort of are unmasking a predisposition to develop clots. In the guidelines, the American guidelines do recommend that if you have had 2 events provoked, you should be on long-term anticoagulation to reduce the risk of having a clot in the future. This with regards to the indication for anticoagulation. Now, the post-thrombotic syndrome, unfortunately, is a very common event. Up to 50% of patients that have clots in the veins close to the thigh or in the upper legs, the post-thrombotic syndrome is disabling, and the treatment is with compression stockings to prevent the damage to the skin and to the tissues due to the fact that the leaky valves in the veins, the valves inside the veins were damaged by the clots, and now the leaky valves cause pooling of blood in the veins. The veins get engorged, they get stretched, they get inflamed. This inflammation spreads to the tissues, and you have these inflamed and painful veins and legs. And so the treatment is with compression in this case. Unfortunately, we don't have any good medical treatment or any surgical treatment for this.
And is post-thrombotic syndrome, so a follow-up question to that is, if this person is considering having a child, so getting pregnant, and they're wondering, would that make the post-thrombotic syndrome worse? And if so, would that be a temporary worsening and it would revert back to how it was after the pregnancy? Or would that be a chronic worsening of it?
So in general, pregnancy is associated with an increase of the pressures inside the veins because you have multiple factors. First, you have high levels of a hormone called progesterone, and the progesterone makes the tissues more flexible because obviously the tissues in the abdomen have to expand to accommodate the growing fetus, and the tissues that holds the bone together have to become more sort of flexible and stretchable because at the time of delivery the baby has to pass in the birth canal. And also the veins, as somehow innocent bystanders, become sort of more pliable, and the pressure is going to make them larger. And this is one reason. The other reason is that when a woman is pregnant, there is much more fluid in the circulation. So they have high volume of fluid in the circulation that expands the vein. In addition, you have that the growing uterus in the belly, in the lower belly, pushes on the veins in the lower belly and also increases the pressures in the vein. So everything contributes to worsening of the vein situation. Whether you have just varicose veins or you have post-thrombotic syndrome, it's going to get worse. Now, Usually this reverses when the baby is delivered and the hormonal situation returns to normal, the fluid amount in the body returns to normal. But there may be cases in which this is not fully reversible and they may be worsening of the venous congestion. In any case, I think that this is not per se a contraindication to pregnancy. Second, with appropriate compressions therapy, the long-term consequences may be reduced and controlled. So I would say if the person that is the woman that has a post-thrombotic syndrome plans to conceive and have a pregnancy, can see a vascular specialist to help with finding the appropriate treatment to prevent worsening of the vein situation, including the post-thrombotic syndrome.
Okay. So switching kind of topics, or not kind of, but drastically, this individual said that he was a veteran and he was stationed in Iraq, and he's concerned that a hazardous environment may have caused his DVT and was wondering if that was possible. He doesn't elaborate on what hazardous environment means exactly. But I can imagine there's lots going on there in terms of physical and mental pressure and maybe environmental factors too that come into play. So what about those types of things in causing blood clots? Are you there, Dr. Campia? Hello?
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 Hi, Catherine. Sorry, my connection dropped temporarily and it was a long gap and I couldn't hear the question.
No worries at all. It happens. So the question was, this person was a veteran and they were stationed in Iraq, and they were concerned that a hazardous, can you hear me?
Mm-hmm.
Okay, and they were concerned that a hazardous environment may have caused their DVT and was wondering if that was possible, but they don't elaborate on what hazardous environment is. So any thoughts on that?
This is a good question. To my knowledge, the only mechanism that I can think of would be if the person was exposed to an environment that has a lot of inhaled toxins that could cause inflammation, and indirectly inflammation can increase the risk of DVT. But I cannot elaborate more because I have no more details. I'm not sort of, I would say, aware of a specific toxin that would predispose to venous thromboembolism besides snake venom, for instance, or some spider bites or some like scorpions.
Okay. All right. That makes sense. What about stress? I mean, is there any link with stress, chronic stress? I can imagine that would be a high stress environment.
Yes, stress per se can activate a number of responses in the body that may trigger also inflammation, but there has never been I would say, a well-documented study that can confirm that a certain amount of stress is associated with a certain risk of DVT or PE. So indirectly, it can contribute, but I wouldn't call call it a major causative factor.
Okay. So now we'll kind of move on to questions, and this is probably the category with the most questions about different treatments and medications.
Mm-hmm.
So this is one question that we get a lot, actually. So this patient is 52 years old today, so happy birthday. But they're on warfarin, and they love it because they love getting their INR checked, and it makes them feel better about where they are in terms of being therapeutic. But they're wondering at what time do you think it would be appropriate for them to switch to a DOAC, if ever?
I would say that if the warfarin is stable and the patient has not had major fluctuation of the INR, there is really no strong evidence that switching from warfarin to a DOAC would be of major benefit. The indication in which I would recommend switching would be if the patient really has had a hard time maintaining the INR within the therapeutic range, or if the patient has developed side effects related to the use of the warfarin, or in other countries there are similar drugs that are in the same class. If the patient has any issues with a diet that require a specific diet that would make it more challenging to maintain a stable INR, in that case switching to a DOAC would be sort of convenient. Sometimes if the patient has a difficult time monitoring, patients may be working in a remote region with difficult access to a healthcare provider. That would be another sort of reasonable consideration. But per se, the fact that you have availability of a DOAC is not does not mandate to stop Coumadin and switch to the DOAC.
Yeah, I think there's so much talk about the DOACs these days that patients almost feel pressured that they should start one. But, you know, Dr. Goldhaber always says he doesn't like to rock the boat. So if a patient is, you know, happy and doing well on the medication, it might be just fine for them.
Absolutely.
Okay, so this question is this person is wondering if it ever makes sense to lower the dosage of a DOAC, possibly even combining or replacing it with aspirin for patients that have adverse side effects from the DOAC.
So the first question that I would have is what kind of side effects? So if the patient is having a stomach upset after taking the pill, the effect may be specific to that pill, and so switching to another DOAC may be appropriate. If the patient has had a bleeding, which would be probably similar no matter what DOAC you are using or anticoagulant you are using, then you have to consider, is the bleeding due to a factor that can be corrected? Is it reversible? And the drug has just unmasked the presence, let's say, of an ulcer in the stomach. So at that point, you have to sort of treat the underlying cause, and if you can sort of remove the risk of bleeding, you can go back. Now with the reduction, usually we reduce the DOACs when the patient has completed the treatment for the DVT or the PE, and usually it's between 3 and 6 months. In some cases it would be appropriate to do it for a little longer. In some patients it can be appropriate to stop at 3 months. In some patients it's better to do the full 6 months. So In these cases, there are two of the DOACs, in particular rivaroxaban or Xarelto, and Eliquis or apixaban, that have shown to be effective in reducing the risk of new clots, even when you reduce the dose. So let's say a patient was taking Xarelto for 6 months at the full dose, 20 milligrams. Then the patient has still an indication to be on a blood thinner. There was a study called the Einstein Choice that showed that the 10 milligram dose, half of the full dose, is as good as the full dose in reducing the risk. The same applies for the Eliquis, the apixaban. There was a study that showed that when you reduce the dose from 5 milligrams to 2.5 milligrams, the risk of clot is the same, and so you can reduce the dose and reduce the risk of bleeding. The question with regards, should someone take aspirin? So aspirin, there were two studies, one done in Italy and one done in Australia, that showed very similar results. The risk of a new clot was reduced about 35%. Now, what is the risk reduction with, let's say, rivaroxaban with the Xarelto, or with the apixaban with the Eliquis? About 90%. So you get the same risk of bleeding, because when they compared Xarelto with aspirin, it was pretty much the same, but you get twice as high the protection. So to me, it's a no-brainer. Aspirin works, but for the same risk of bleeding, a DOAC doubles or more than doubles your protection. So I would say, unless there is no sort of possibility of taking Xarelto or taking Eliquis, at this point, you can go on an aspirin. But otherwise, aspirin is not a first choice.
Okay. So talking about DOACs, has there, and I think the answer is probably no, but is there any data available about the long-term use of DOACs, particularly in regards to liver and kidney function?
Mm-hmm. Yeah, the data that are available are sort of the first DOAC that was introduced was dabigatran, and then which was called Pradaxa. Then the second one was Xarelto, and the third one was Eliquis. The fourth one was edoxaban or Savesa. Now, the longest available is Pradaxa. It's been about 10 years. And for 10 years, we know that there has been no signal that they damage the liver or they damage the kidneys or that they cause any long-term consequences. So far, for at least 10 years, we can say we know that they are safe, and we have not had any red flags. So is it possible that in the future things will change? Yes. There is a very active surveillance system in which the FDA receives specific sort of cases of side effects, and this system has worked pretty well so far. So if there was even a rare effect that occurs only, let's say, 1 in a million people, now we should have a way to detect it. And so far, to my knowledge, we have not.
So we talked a lot about DOACs and talking about warfarin. This patient writes in about concerns over bone loss caused by warfarin. And if just kind of wondering if you had any additional information about that.
Yeah, so warfarin has been used for several decades. And more than warfarin is the heparin and low molecular weight heparins that have been associated with bone loss. So in general, we tend not to keep patients on low molecular weight heparins for years and years just because of that. Oftentimes, we have to keep in mind that patients who are on warfarin for several years are elderly and they may have other causes of bone loss, and it's always a little challenging to discriminate whether the bone loss is due to the warfarin or is due to aging or sometimes to the other many medications that patients are on. So I would say common sense recommendation that are valid for anyone to prevent bone loss should apply to patients that are on chronic warfarin. Many times we have to keep in mind that patients on chronic warfarin are protected by life-threatening complications. Let's say patients that have a mechanical valve in the heart. That's the only drug that oral drug that is approved. The other drugs, actually, the DOACs, should not be used because they increase the risk of or don't protect from clots. So I would say it's always a matter of risk and benefits. Even if there is a small risk of bone loss in some patients, the benefit outweighs most of those risks. So.
Okay. A lot of risk and benefit discussions, I think, need to be had with healthcare providers around
Yes.
topics. So a practical question, how much alcohol is safe to drink on the DOACs? And is there ever an occasion where if they're planning on having multiple drinks that they should skip their DOAC that day?
So there are two aspects to the alcohol drinking. So DOACs are less susceptible to the effects of alcohol than warfarin. The reason is that alcohol affects the liver function, and warfarin acts through effects on the liver. So if your liver is not working because of the alcohol and you're taking warfarin, your blood is too thin. Now the alcohol may also have effects on the platelets, so the platelets may be less sticky, and this applies to any DOACs. Now the DOACs, some of the DOACs, they are cleared by the liver more than by the kidney, and let's say apixaban or Eliquis is the prototype of a DOAC that is cleared mostly by the liver, about 3/4, and only 1/4 by the kidney. So in this case, drinking alcohol may also cause a higher level of apixaban with or Eliquis and the risk of bleeding. My recommendation is that alcohol in moderation, one drink, one glass of wine in patients who are on a DOAC is okay. More than that, I would say no. Honestly, I would not recommend, I would strongly discourage someone from holding their blood thinner so that they can drink more. Drinking more is never safe, and they expose themselves at risk of falls. And even if you don't take your Eliquis the night that you plan to drink a lot, you still are on a blood thinner and you have the effect of the previous dose, and if you fall, you're at risk of more bleeding. So my recommendation is strong not to drink more than one glass of wine or one drink per day.
Okay. But again, one of those things where if this is something that, you know, is going to be a barrier to your medication adherence, and you'd probably want to talk to your healthcare provider about alternative strategies.
Absolutely.
Okay, so a couple questions about what happens if you fail either warfarin or a DOAC.
Mhm.
Kind of what are next steps after that if you have another clot while on an anticoagulant?
Yes. So, like all drugs, anticoagulants are not 100% effective in treating a certain condition. So, you still have a small proportion of patients that, despite being consistently taking their medication, they may develop another clot. And this may be due to a number of factors that would be probably too long to discuss now. Now, what do we do in that case? So we first of all use in the immediate treatment an anticoagulant that we know for sure is going to be in the body at the right level. So we use either an IV anticoagulant, heparin, or we use an injection, a subcutaneous injection, such as Lovenox, or another one similar to Lovenox called alteparin. So we switch to that because that gives us the best guarantee that the drug is in the system. Now, once the patient has been stabilized on this new drug, then the question is, what alternative agent should we use? So there are no studies that have looked into this specifically, and we use our sort of experience and the knowledge based on the other studies that have been done. And my approach and the approach of many of my colleagues is that if you have, let's say you were on warfarin and you failed the warfarin, then if you can be switched to a DOAC, you should go on a DOAC. If you cannot be switched to a DOAC, we are restricted to the use of the injection, the low molecular weight heparin, such as the Lovenox. Now, if you were on a DOAC and you failed the DOAC and you got a clot, then you can use another DOAC because they're similar in the way that they sort of thin the blood, but they have significant differences. They are not the same drug. They are very different drugs, and it's likely that another DOAC would work. So if you are on Eliquis and Eliquis didn't work, you can can start Xarelto or Saveza or Pradaxa. Pradaxa is another interesting choice because it has a mechanism of action that is unique and different from Xarelto and Saveza and Eliquis. So many patients, I do go from Xarelto or Apixaban or Eliquis or Saveza to Pradaxa because it has a different mechanism of action. But there are no fixed rules, and patients may also have preferences. And again, is a decision that the provider can discuss with the patient.
Okay. So we're going to do one more question from the treatment medication and then move on to recovery, just so we have, spend equal time on that. So the last question is from a woman, and she has really heavy periods on a DOAC, and she was wondering what the best course of action or alternative might be for her there.
Yeah, so this is a very common situation. So first, my recommendation in general is to see their gynecology physician to determine whether the bleeding is due to possible abnormalities that may have not been diagnosed. The most common is actually the presence of uterine fibroids that may have not been causing any issues until the patient starts a blood thinner, and the manifestation is excessive bleeding during the menstrual cycle. So if the patient has excessive bleeding due to fibroids, then the decision is based on the best treatment for the fibroids, and that's why there should be a collaboration and a conversation between the physician managing the blood thinner and the gynecologist. If the patient doesn't have fibroids and it's just heavy menstrual cycle, then there are pharmacologic options to temporarily stop the menstrual cycle to the extent that allows for the treatment of the DVT. In some cases, these are hormonal treatment with the use of hormones as a pill. Sometimes there are hormonal treatments that can use subcutaneous implants. In some cases, there are treatments that are with intrauterine devices. So the choice of the best treatment is based also on the gynecological history of the patient. And again, this needs to be done in a conversation between the doctor managing the blood thinner and the gynecologist.
All right. So this patient is wondering, how do you deal with changes in your body after having a blood clot, like heart rate increases that you did not have before?
Yes, so I would say that there are two group of diseases. The one is the DVT, the other one is the PE. And in this case, obviously, the disease, you can have both, but the manifestations are different. If you have a DVT, usually the manifestation is the swelling, the pain in the leg, or this discoloration, the inflammation. And those can be managed usually with a blood thinner, and they tend to go away relatively quickly. Sometimes they have pain that can persist, and the pain can be sort of managed with sort of analgesics such as Tylenol or the use of compression stockings. Then with the DVT, the long-term consequences that we already talked about is mostly the postthrombotic syndrome, and that is best managed with the use of compression therapy for the long term. With regards to the effects on of the body of a pulmonary embolism, obviously the first can be the rapid heartbeat, the tachycardia. Then the patient may have shortness of breath, may have chest pain if the clot caused some damage to the at the surface of the lungs. And so again, each issue can be addressed specifically, but the blood thinner usually helps because the clot gradually is dissolved by the body, and the heart rate tends to recover, the shortness of breath tends to disappear, and the patient gradually returns to the baseline level, and the pain can be treated again with analgesics. In a small group of patients, there may be a persistent sort of reduction in the ability to exercise. Patients may complain of shortness of breath at a level of exercise that they could handle normally before, or patients may complain of the inability to do things that they could do, and now they are fatigued and they feel that they are not what they used to be. These are situations that need to be investigated because they may be a form of long-term consequences. The shortness of breath can be part of what we call the post-PE syndrome, and that we don't know too much about yet. The shortness of breath can also be due to persistence of clots in the lung circulation, what we call chronic thromboembolic pulmonary hypertension, and these clots cause an obstruction to blood flow passage, and this obstruction causes an increase in the pressure inside the lung circulation, and the treatment in some cases is surgical, and patients may return to normal after they have undergone the surgery. Usually this is a small percentage, about 4% of the patients that develop this complication.
Okay, and how long after a pulmonary embolism does it take the lungs to heal? At what point should they kind of start worrying that maybe something else is going on, like CTEPH, which you just mentioned, you know, and go back to their doctor?
Yeah, so there is a wide variability between patients. I have patients that start on a blood thinner, and within a few days they feel significantly better, and within a few weeks they feel back to normal. I have patients that instead continue to have shortness of breath for several weeks, and then it takes you know, 2, 3, 4 months to go back to normal. The chest pain usually goes away within a few days to a few weeks. I don't remember having patients that have persistent chest pain because of the clots.
Okay. Can a person who's on an anticoagulant receive chiropractic care and deep tissue massages?
So the overall recommendation is not to, because both situation can be associated with the occurrence of internal bleeding, what we call hematomas, and these hematomas, especially in the muscles of the legs, can be very large because the tissue can accommodate a lot of blood, and they may be at risk of long-term damage to the muscles in the area where there is the bleeding. Also, the chiropractors, in general, I am relatively sort of cautious about recommending chiropractor because there may be additional vascular risks associated with it if it is not done by a very experienced professional, and even experienced professionals sometimes can cause damage, and in a patient with a blood thinner even more. So if there is no absolute need, I think I would avoid the chiropractor, and definitely I would recommend against a deep tissue massage on anticoagulation.
Okay. This patient wants to know, is it possible for a DVT to get worse even with full management, such as medications, compression, etc.?
So if the DVT gets worse on a blood thinner, that's an indication that the blood thinner is not effective, and the solution is to use another blood thinner instead. Decompression per se does not affect the resolution of the clot, may help with the swelling and the pain. So the main issue would be, is the blood thinner working or not? And if it is not working, it should be changed.
All right. How often should people stop and when they're on long car rides to get out and walk around? This person's wondering if it's a strict every hour or if there's another recommendation.
I would say that an hour and a half is sort of reasonable. If the person is concerned, they can use some compression stockings for any long trip, whether it is in the car or on a plane or on a bus or on a train, and the compression can help. I would say an hour and a half is not much sort of different risk than every hour. So I would be relatively flexible in that time. But sorry, a recommendation: stay well hydrated. That's very important.
Yes, and then that kind of makes you need to stop every hour and a half to go to the bathroom anyways. So it's a good cycle to get into.
Yeah.
Okay. So this patient has had hypertension since they were 18 years old. And they've had a pulmonary embolism. And they're wondering, what is the difference between a pulmonary embolism and pulmonary hypertension?
So the pulmonary embolism is the formation of clots inside the vein, and the clots dislodge from the vein where they form, and they travel along the veins in the circulation until they reach the lung circulation, and the clot at some point is larger than the vein where, or in this case we call it pulmonary arteries of the vessel where the flow is going, and it stops the flow, and that is a pulmonary embolism. So the pulmonary embolism is this clot that goes into the lung circulation, and when it goes there, the clot blocks the flow, and when the flow is blocked, the heart has to pump stronger to make the blood go through the other vessels, and this stronger pushing of the heart into the lung circulation causes an increase of pressure, and that's what we call pulmonary hypertension. So the clot may cause pulmonary hypertension, but pulmonary hypertension may be caused by other things besides the clots. So not all patients that have clots develop pulmonary hypertension. If the clot is small, you may still have enough passage of blood without too much pushing from the heart. And not all patients who have pulmonary hypertension is because of clots. So you have a group of patients that have clots with pulmonary hypertension, a group of patients with clots without pulmonary hypertension, and a group of patients without clots but with pulmonary hypertension. And they are very, very different group of patients.
Okay. So this is a question, we don't get many questions about renal arterial thrombosis, but this patient had renal arterial thrombosis with no known contributors, and she's just trying to understand why this happened and wants any tips for how to keep herself healthy going forward.
Yeah, so I would say that all healthy lifestyle recommendations, including a diet that has a good variety of fresh fruits, fresh vegetables, all these elements, good olive oil, have antioxidants. Antioxidants keep the inflammation low, and the inflammation low reduces the risk of clots. Being active, activity reduces the pooling of blood in the legs, and so you have more blood circulating, and there is less risk of small clots forming, and then the clots may extend. Also, avoiding the use of certain recreational drugs such as alcohol. Drinking a lot can increase the risk and is never beneficial. So all these lifestyle recommendations also work to reduce the risk of clots.
All right, so just a general heart healthy lifestyle and kind of some common sense things will go a long way.
Yes.
Okay. So I guess a last question that we have is, do you have a preference for any particular DOAC? I know that different ones tend to work better depending on what the patient's situation is. So any kind of guidance in how patients should go about evaluating the different options available to them?
So I would say the DOACs in many ways have very similar sort of safety, very similar sort of effectiveness or efficacy, and there are some considerations that doctors may keep in mind in the choice. For instance, does the patient have a reduced kidney function? A DOAC like apixaban or Eliquis has less risk of becoming sort of too strong if a patient has a lower kidney function compared to the others. In some cases, the blood thinner may not be indicated if the patient has had a previous stroke, such as Saveza, and for some indications. So the doctor is going to decide what the medical benefit of one versus the other is going to be. There are also some practical issues in which the patient's preference may be important. Some drugs may require, after the diagnosis, the use of injection. So in particularly, Pradaxa and Saveza need to have a week of treatment with an injection before you can start the pill. Patients may not want to do that, and they say, why should I do the injection? There is, a different drug. I have to inject myself. It's painful. I have bruises on my belly when I can just take the pill. And let's say Xarelto and Eliquis, you just take the pill. You don't have to use the injection. So this is a patient preference that should be kept in mind. Now, another difference between the DOACs, some like Xarelto or Saveza are once a day. Others, such as Pradaxa or Eliquis, are twice a day. And some patients may say, I don't want to take 2 pills a day, just one is enough. And so they may say, well, I prefer to take Xarelto than Eliquis or Pradaxa. Or let's say Xarelto, you have to take it with food. In theory, the recommendation is with dinner. So patients say, well, I have a very little dinner. Sometimes I don't eat dinner. So can I take a drug that doesn't require taking, you know, a meal with it? And so apixaban Eliquis works better for that patient. So based on all of this consideration, the doctor is going to give a first sort of recommendation, and the patient may have, you know, the final saying based on the best treatment for their condition.
And just a plug for a resource that we have developed, and we worked with a bunch of pharmacists and doctors to put together an anticoagulant comparison chart, which is on the NATF website, and it compares all the different anticoagulant options that are out there. So you can print that out and bring it to your clinician to have a conversation with them if you're wondering which one is best for you. And we also, it's going to be featured in the next issue of the Beat. So if you sign up to receive our printed bi-monthly newsletter, you will get that delivered right to your door. So that is, oh, go ahead, Dr.
I wanted to just add a little sort of consideration. I've been using exactly that table to teach our residents here in the hospital, and they have been extremely sort of grateful that I brought that table, because they find it extremely useful. So thank you for bringing that up.
Oh, well, I'm glad to hear that you're using it. That's wonderful. Let us know if you need more, and we'd be happy to drop them off.
Thank you.
Yeah, of course. And we are out of time for tonight, but thank you, Dr. Campia, for so, you know, graciously donating your time to us to answer all these wonderful questions. I was so impressed by the questions. We've got, you know, clearly such a really smart, educated group of patients that are actively trying to, you know, manage their thrombotic conditions. So thank you for all your guidance and your input and wisdom and answering their questions this evening.
You're very welcome. It's been a pleasure, and I'm looking forward to our next webinar.
Absolutely, and just so everyone knows, based on feedback from our attendees here, as well as a focus group we did, we're actually changing the model of our online support groups. We are going to start launching monthly webinars, which will be emailed directly to you, educational little 5-minute videos on different topics. So you'll be able to watch those every month. They'll go out. I think the next one's scheduled, or the first one's scheduled to go out next week. And then we will have quarterly Ask the Expert sessions. So just like we did tonight, a chance for you guys to ask all the questions that you have, either related to the information that we sent out or something that you have going on. So we're hoping that this model will better meet the needs of you guys. So we always welcome your input and your feedback, and thank you so much for joining us tonight. And thank you again, Dr. Campia.
You're very welcome. Thank you, Catherine, and thank you all the staff at NATF for this great opportunity.
Okay, wonderful. Have a good night, everyone.
Bye-bye.
Bye-bye.